Hi, good morning, everyone, and thank you for joining us this Brisk Tuesday, our first program in November. We would like to give a warm welcome to Mark Brownstein, who's the director of Emerald Medicare, and he'll be presenting on everything Medicare, which is a timely topic, especially because we're now in open enrollment. So please enjoy Mark's presentation, and if you have any questions, please enter them in the chat or the Q&A, and Mark will be fielding them live. So without further ado, Mark, thank you so much for joining us this morning.
Well, a pleasure to be here, and thank you all so much. Just trying to make sure you can see the one screen, Sarah, correct?
We can.
Okay, great. Well, welcome everybody. My name is Mark Brownstein from Emerald Medicare, and I'm honored and pleased to be here today to present to you a really an overview of Medicare during this open enrollment time. This is a really busy time of the year for our office, but also busy for you in that you are probably being inundated by TV and radio and mail coming to your mailbox on options and choices within Medicare. It is very hard to decipher all of that. And it's really an opportunity for many people to evaluate their plans. The truth is that 1 in 10 people in America actually change their plan, their medical side of their plan during open enrollment. 3 in 10 actually change their prescription drug plan. So a lot of activity, a lot of opportunity, a lot to discuss. And on the screen here, you see my team. I am the gentleman in the middle. My assistant, Michelle, is on the left. The boy, the kid, the adult on the right is actually working out of New Orleans as he's going to graduate school, helping us out. And we have another person by the name of Kerry, who's helping us now during open enrollment, doing some very important things. So, people can't sleep about this issue. And it's really amazing in many ways that people, for the first time in many people's lives, have had to make this Medicare decision for the first time because they have had healthcare coverage through their company or through their spouse, and they haven't really had to make the choices that Medicare gives them. And so if you can't sleep, try and find somebody who really understands this business. There are rules, there are deadlines, and it's important to really make the right decision based on your health and your budget. But Medicare can be confusing, and depending on where you are with Medicare, there are many choices to be made. I'm going to put up some poll questions so that I can get a feel for the people who are on this call. These are simple questions. If you can answer them, it would just give me some insight as to the people who are on this call. Again, I appreciate you taking the time, just a few seconds to answer 5 different questions to get a sense of the people on this call. But yes, Medicare is confusing. There are different options, there are different plans. And Part A is separate from Part B. And so the timing of all of that are things that people need to make sure that they do right. I work with many financial planners, attorneys, CPAs, and they really want to also help their clients avoid any mistakes, avoid any penalties. What do I need to do when I turn 65? Do I have to get Part A and Part B? Or, I'm ready to retire, but I have coverage through my spouse. And so what are some of the choices? But the advice that I provide is often when people are getting ready to retire, are getting ready to turn 65, I say 6-9 months before either one of those events, reach out to somebody so you know what to expect, so you can have peace of mind. So as we start this presentation, this webinar, there are some changes that I want to speak of up front. And there are changes that are going on within a number of aspects within Medicare that you should be aware of at the very least. And that for 2022, the Part B deductible, and some of you realize that Part B deductible based on the type of plan that you're on. But the Part B deductible is going up from $203 to $217. And it's only paid once during the year. So that's a change, that's an increase that will be implemented January 1st of 2022. But also CMS, which is the organization that oversees all of the Medicare components. In late September, the average premium for the Advantage plans are actually lower than 2021 by a little bit, not a lot. It's still about the features and the benefits that these Advantage plans offer. These Advantage plans are considered Part C and Part D, and I'll cover that in more detail later. One of the big changes, though, is the Part D deductible. That's the prescription drug coverage deductible. It was $445 in 2021. It is now going up to $480 in 2022. That's actually a significant difference. This only impacts those folks who are on medications that are Tier 3, Tier 4, or Tier 5. For those of you who are on generic medications, you have not had to address the deductible. But for those of you who are, and many, many are, that deductible has gone up. Once you meet the deductible, yes, the price will go down. And again, I'll cover that later. But these are changes. The Med Supplement or Medigap plans that are out there actually have held steady through COVID. But the rates have increased in all states. I'm going to say by the average of about 6%. If you take out 2021 as a year in which things really were managed sort of neutrally, it was really 3% a year, but rates have gone up. The income adjustment, that's an income adjustment for people who have earned good money in prior years. Those changes are also being suggested. In terms of the tiers, there are 5 tiers, and I'll go over that as well. But again, changes are looking for 2023 on this income adjustment, which impacts people's Part B and Part D. The original Medicare dental and vision. Now, this is truly being discussed often. There's a lot of discussion about the dental and the vision, and it's not going to change in 2022. But clearly 2023 is going to have, I think, some activity. A lot of the Advantage plans, again, the Part C and Part D plans, these plans have increased their offerings for dental and vision. And so a lot of people are calling these days to try and find out if, in fact, there are some opportunities to get some dental and vision that they may not have had opportunities to take advantage of previously. So what is Medicare? Really simple and quickly, it's the government insurance program for people over 65, but it also supports people who are on Social Security disability for 24 months. So in the 25th month, people who are on SSDI have access to Medicare, just like people over 65. And that's a good size of the population, maybe 10%, who really are looking at solutions for themselves in their 25th month on SSDI. This whole area of Medicare is administered by CMS. CMS was involved quite a bit around the nursing home scenario for COVID, but this is, the enrollment is actually through the Social Security Administration. People are often confused with, Social Security is 62, you can start, Medicare is 65. They are the same department, the same website, but it is enrollment is through the Social Security Administration. The Medicare is not connected to veteran benefits. I actually speak to a lot of veterans, I help them, and I assist them because Medicare and VA benefits are separate, but can support veterans in a very unique way. So I really, I'm grateful to be able to support them. So when people are getting closer to retirement, or people are looking at their health insurance and for Medicare, this is about choices. As I said earlier, it's choices that they are not used to making. And at age 65 or post 65 in retirement, they are being put in a position where they need to sort of evaluate their health and their budget. In some cases, they're looking at their group coverage. The group coverage that people are offered sometimes is very good, and sometimes it's not so great. And sometimes the spouse is actually paying far more than they would on Medicare. So it's really about looking at the group coverage and looking at it as it compares to Medicare. Medicare, in some cases, for people are a bargain. And for some people, their Medicare is more expensive than what they're paying through their employer. Remember, the employer is subsidizing the healthcare coverage. And so when you have the choice between Medicare and group coverage, it's important to evaluate the details of the group plan. What are those copays? What are the deductibles? What are the out-of-pocket maximums? And compare them to Medicare. So when I help people, I look at that group plan, I look at the retirement coverage, and we compare them to Medicare and see if there is a benefit in utilizing Medicare. These plans vary tremendously by state and by county. There are 4,000 counties in this country. They each have many, many advantage plans, which are Part C and Part D. An area like where we live now, there could be 20 to 30 different choices for advantage plans. That's where the confusion comes in. Hard to decipher one from the other sometimes. In New York State, there are 3 different types of pricing based on where you live in the state up through Buffalo for the other type of plan, which is the Medigap, or otherwise called Med Supplement. But in most cases, the states are fairly regulated in that regard. But state and county, it does impact the kinds of plans and the pricing that are available. At the end of the day, all of this discussion around Medicare is about what best suits your health and your budget. And so New York is so unique, and it's so great to work in New York. My area is really New York, New Jersey, Connecticut. New York and Connecticut both have the tremendous opportunity where you can start with an advantage plan, Part C and D, and move over to a supplemental plan and back without any health questions, any underwriting, or any pre-existing conditions. That is only the case in 4 states around the country. And so New York is very unique and really gives people tremendous options. So just a little bit of history on Medicare. It really started back in the mid-40s with Truman. He created a national insurance fund for all Americans, but it really was Dwight Eisenhower and Kennedy who really sort of looked at these uninsured, engaged voters and wanted to create health care for them. But in '65, Johnson really put into place what is still in place, Part A, which is hospital coverage, Part B, which is all of the outpatient services, the doctors, the x-ray, the diagnostic, all of that is still Part B. But in the '70s through the '90s with the various presidents, they developed Part C, which is C for choice. And this really gave private companies the opportunity to create plans that were uniquely designed for a marketplace, whether it be different parts of the country or different chronic conditions. They created their own private managed care plans that, again, people love, and is truly the most popular plans in America, but it is truly C for choice. George W. Bush created the prescription drug plan, Part D, and that's, again, still in place today. There's more than 52 million people on Medicare now, and there'll be 80 million by 2030. 22 million have a Med Advantage plan, again, Parts C and D, and 13.5 million have a Medigap or Med Supplement. And actually 6 million have only A and B, which is fascinating. So original Medicare, people love original Medicare because it gives them access to any doctor anywhere in the country that takes Medicare. The challenge with original Medicare is that it is one, Part A is free, Part B has a premium, but A and B combined is 80%. So 80% of Medicare approved charges puts the individual at a level of vulnerability or risk for 20% of all Medicare approved charges. So the question is how do people cover that remaining 20%? Because there's no limit, there's no cap to that 20% if you're on A and B. But again, people like it because they can go to any doctor anywhere in the country that takes Medicare, but it doesn't include Part D. So one has to get a Part D plan, honestly, or one would be penalized if one decided to get Part D at a later date. But Part A, premium-free hospitalization, inpatient hospital care, skilled nursing, and it's free if you or one spouse has worked in the system and paid into Medicare for 10 years or more, okay? And that's for a person and their spouse. Part B, on the other hand, is not free and is currently $148.50 and going up to $153 per month per person in 2022. This is indexed for income, and I will go over that in a moment. But Part B is all of the outpatient services, as I mentioned earlier, preventative x-rays, diagnostic labs, durable medical equipment, all Part B. Part B is a core of this, and many people are delaying Part B, rightfully so, because they don't want to have to pay that $148.50 or $153. On the other hand, delaying Part B when one should have it can create a penalty. Now, original Medicare does not cover everything. It doesn't cover long-term care and chronic care, custodial care. The routine dental and eye care, these are the kinds of things that the Advantage plans are bringing to the table and improving each year. Hearing aids, acupuncture, these are the kinds of things that are constantly being talked about on the airwaves. These are opportunities and ancillary benefits that really help people with some of the other aspects of their life that they want to see covered, or at least get a substantial discount from. But if we're talking about cataract surgery, we're talking about diabetic eye checkups or glaucoma, yes, that's covered. Those are medical. But again, the routine work is not covered by original Medicare. So is Medicare automatic? Medicare is automatic when you are collecting Social Security of any type at age 65. So if one is collecting Social Security at age 62, getting benefits from an ex-spouse, Social Security disability, at 65, you will get a Medicare card with Part A and Part B. Now, many people don't need to have Part B and don't want to pay for Part B. So if a card was to come to your home with Part A and Part B, on the back of the card, it would say, if you want to reject Part B, return the card and you will get a Part A only card. Again, there's no cost for Part A, but Part B, there is a cost. So there are many people who have been paying on Part B and didn't need to pay for Part B because they never actually rejected it. But again, it is automatic if you're collecting any type of Social Security. On the other hand, if you're not collecting Social Security of any kind, you need to be proactive. So people who are working for, and this is important, working for a company larger than 20 employees do not need to do anything if they don't want to get Part B. They can get Part A, but Part B, again, has a cost associated with it. For people who are unemployed, self-employed, or working for a company of less than 20 employees, they need to be proactive if they're not collecting Social Security. So one can go online, very easy to go online. One can place a phone call to the Social Security office and sign up. yes, there is a window. There's a 7-month window in which one can sign up. It is the month of your birthday, 3 months before, and 3 months after. But I always encourage people to really look at this before your birthday so that you have no delays, you have a smooth transition to whatever coverage you have and or Medicare if that's your choice. So yes, Part B and Part D is voluntary. Delaying Part B and Part D when you have to get it can create a penalty. But I'm going to repeat, unemployed, self-employed, or people working for a company of less than 20 employees need to be proactive in getting themselves onto Medicare. So this is important because Part B is often the questions that we hear about because nobody wants the penalty. So this is one of the slides that I consider to be really important. I believe that there's an opportunity for you to download this slide and the next slide. But these are really the enrollment periods that everyone faces in America. The initial enrollment period I just mentioned, it's the 7-month window around your birthday. Again, unemployed, self-employed, working for a company of less than 20 employees. It's a 7-month window. But really, 3 months before, 2 months before, 1 month before, I would suggest being proactive and moving up forward and understanding the rules and timing of Medicare. The annual enrollment period we are in the thick of now. This is a very busy time because people are evaluating their choices, their plans, looking at pricing. 3 and 10 again are changing prescription drug plans because you can and should evaluate them. But this period is for a January 1st enrollment period. So any decision made by December 7th has an effective date of January 1st. It truly takes the carriers quite a bit of time to actually get everything taken care of relative to the new plans for the carriers for all the volume. The open enrollment period is one that is very, very rarely discussed. And for people who go in and sign up for an Advantage plan, which is C and D, and let's say they go to their doctor's office January 15th and they find out their doctor doesn't take that plan. They're shocked, they're dismayed, they don't know what to do. There is this open enrollment period that is not marketed at all. And I work with medical offices, so I do get these calls, is that people from January 1st to March 31st can in fact make a change to their Med Advantage plan to another Med Advantage plan for the following month. So by March 31st, it would be for April 1st, but if one decided January that they wanted a new plan, they can change for February 1st. This is a unique time period for people who are dissatisfied with their choice on the Advantage side or the Part C and Part D plan. This is helpful for many. The special enrollment periods. There are many special enrollments. When people call me mid-year, they are often trying to make a change to their plan, but it's off-season. And so there are special enrollments that exist, and there's about a dozen of them that are important. But what's important is the most significant one that we see is, of course, the one where people are losing their group coverage. So they decided to retire themselves and or their spouse. They decided to retire the end of June, and they want to make sure that they have a smooth transition July 1st over to Medicare. So that special enrollment is actually called loss of employer coverage. And so that's one in which would be implemented to be able to make that change any time of the year when they were retiring. There are other special enrollments. If you move from one county to another county, you have a special enrollment. If you have been accepted into a program called EPIC, which is a New York State pharmaceutical program, which I'm a big fan of for people who qualify, that's another special enrollment. If you're coming in and out of a rehab or a nursing home or an assisted living facility, I get many calls with people whose parents are in transition and looking to change their coverage during the year to enhance or change their coverage. That's a special enrollment. Getting on and off of Medicaid is a special enrollment. So again, mid-year, there are some options that are available. But for me, the most common one is the people who are retiring and who are losing their employer group coverage.
Mark, we have a couple of questions that
Sure.
came in about enrollment periods.
Sure.
So our first attendee wants you to explain what is an Advantage plan and how is it different from traditional Medicare?
Okay, so coincidentally enough, that's the next screen. So is there another question before I sort of go on to this one?
We have another two that came in, so perfect
Okay.
timing for that slide.
Okay, are they connected to the same kind of question?
Slightly different. So I'll read them, and if you're going to cover them on the next slide, then we'll tackle them that way.
Okay, go ahead.
So the next question is, participant is 69, retired January 2021, and has Medicare A, B, and D with a Medicare supplement and additional coverage for dental, which covers really very little. The participant is looking for a plan that covers all vision and dental and would be interested in the same for their husband. You know, how would they start their search for their Medicare plan of choice?
Okay, and the next question?
The next question is, if I'm on an Advantage plan and have a pre-existing condition like cancer, then when I switch to original Medicare, will I be discriminated against by supplemental insurance companies for having a pre-existing condition?
Okay, well, I'm going to answer the last question first because the other two I believe I will address within this slide. But New York, again, is the one of the only 4 states in the country where no pre-existing conditions exist. No underwriting, no health questions. If one switches from an Advantage plan to a supplemental plan, you have a unique opportunity to switch without any questions from any carriers. That is not the case in 45 states around the country. So often I say to people, before you leave New York, call, because you want to make sure that you wind up with a plan that is transferable to another state. So yes, on an Advantage plan, if things turn, if it turns mid-year, you can actually make a change to a supplemental plan mid-year. The challenge is the prescription drug side. So the prescription drug side rules are actually different than the Medigap rules. Medigap is a all-year enrollment. And so that's nice, but you can't necessarily get a prescription drug coverage plan unless you have some kind of a special enrollment like a MOVE or EPIC or something along those lines. Again, in terms of the other questions that were asked, Sarah, and the people listening, I will address it in this slide. And this is to me is a core component of this presentation, in that these are the 4 choices that people have on Medicare. It's really straightforward, is that the employer group plan may very well be the best plan for the individuals. I often look at people's employer group plans. I'm very objective and very honest about whether people should stay on their employer group plan because it has some of this dental and some of this vision, right? And they are getting some reimbursement, or they are having their son or their daughter or their wife covered on this plan. But in some cases, the prices are high. Could be a high deductible plan, and people have met maybe that high deductible. So evaluating an employer group plan is key to making sure that you understand what you have before you even consider leaving it, because once you leave an employer group plan, you likely cannot get back on it. So I take this very, very seriously in terms of looking at the copays and the deductibles and out-of-pocket maximums. Those are really the 3 areas I look at. Original Medicare, again, is A and B. About 10% of Americans have only A and B for various reasons. Again, it's because they love the fact that they can go to any doctor anywhere in the country that takes Medicare. The challenge is that it's only 80% coverage and you need something else. Again, to answer some of the other questions that were asked, Sarah, 3A and 3B is the Med Advantage plan. This is parts C and D. This is the most highly marketed plans in America. These are the plans that are on TV. These are the plans that are touting free dental, free vision, that you get your Part B payback. They are acupuncture, but they're managed care. They are private insurance companies' design of Medicare's version of how they're going to offer this to you. So all of the carriers that you would be familiar with, plus many that you aren't familiar with, offer these plans. A carrier could have 4 or 5 plans in your county that they offer. Some of them will have more dental than others, and some will have more vision than others. To specifically answer one of the questions asked, the way to go about this evaluation is to start with the doctors. So one of the areas that we spend a ton of time on as an organization is looking at doctors and looking at medications. When you look at the doctors and you look at the 7, 8 carriers that are in your county, one has to sort of determine whether those doctors are in your network, because these plans are all in a network. Some of them are larger than others. Some of them are national, some of them are regional, some of them are local. So if you travel or if you go to another state for coverage, all of those are considerations. So when we look at people's doctors, we ask them for doctors, facilities that they use, so that we can really look at how comprehensive you need coverage to be to fit your healthcare needs. There may be 8 doctors that you frequent, or maybe 2 doctors that you frequent, and another handful of doctors that you maybe see every 2-3 years. Some people will actually change their doctors to get the dental and the vision, because some plans have exceptional dental and vision, but their network is small. And so we believe that starting with the doctor evaluation is key. But if you were to tell us that not only are the doctors important, but also some dental and vision is important, that's the work that someone needs to do on your behalf, because there are so many choices, and the more information anyone has, the better. Now, there are HMOs and PPOs. An HMO means you are tied to that network. Whatever the carrier may be, you need to go to doctors in that network. If you're in a PPO plan, it means you can go outside of that network, but you're going to pay more for the service. So people like PPO plans. It gives them the extra bit of flexibility, but 95% of the people that I work with who are on a PPO plan are generally going to doctors and facilities in their network. They like that peace of mind. Not all carriers offer a PPO plan. Now, these Advantage plans include a prescription drug coverage. No additional cost for the prescription drug plan. So you have both the medical and the prescription drug plan in one nice package. Now, 90% of the country has a 0 premium plan in the county that you live in. It doesn't mean it's the best plan, and the plan could be $20, maybe the plan could be $30, but it's certainly not as expensive as the next option that we'll speak of. So again, these Advantage plans are a network. They are filled with copays. And so when people utilize any of the services, whether it be primary care or specialty or an MRI or diagnostic or hospitalization or surgery, everything has a copay. And so my comment to people often is that when you look at an Advantage plan, it's a pay-as-you-go, similar to what you have now. You have copays, you have deductibles, you have out-of-pocket maximums. But you can expect, if you are hospitalized or have surgery, to get a bill of between $1,000 and $2,000. And so, even though the maximum out of pocket is high on these Advantage plans, it's over $7,000. There are very few people, if any, that I have ever seen that have gotten to that amount. But they do wind up having to pay out of pocket, even though they may wind up with a zero, I repeat, zero premium plan. You're still paying your Part B premium. So always that Part B premium will be a part of your Medicare life forever. Right now, it's going to be $153 in 2022. So Part B is a part of it, but the C and D piece, the part that's on the screen for 3A and 3B, could be as low as zero premium, could have dental, could have vision. But I always say, let's look at the doctors first. The Med Supplement area is called Medigap also. These are plans that are original Medicare, and they are the plans for people who have money to be able to afford the premiums. The premiums range from $100 to $300 a month, depending on part of the country that you live in. It does not include prescription drug plan. So the average prescription drug plan is between $15 and $20. But again, there's 20 different prescription drug plans, if any. There's more than that, but they vary in price. And again, the work that we do is to evaluate the medications you're on, the frequency, the dosage, and the pharmacies that you use, because the pharmacies that you use make a difference in terms of the pricing. Again, these are great plans. They have a higher premium, and they're utilized all over the country. This is not a network.
Mark,
Yes,
we have another question that came in about managed care.
sure.
The attendee is asking if a managed care plan will make decisions about what they cover or deny in opposition to physician recommendations or orders. Is this how managed care operates? And is traditional Medicare more likely to approve a doctor's order or recommendation?
That's an excellent question. And the answer is managed care is looking to cut costs. I would say that the Med Supplement, Medigap plan is much more likely to pay the bill and not to challenge it. The Medigap plans are really truly just a bill payer. But the managed care is exactly that. They're managing their care. Now, the one thing that does apply to this question is the appeal process. The appeal process works. And so if there is something that is denied, I can tell you that 80% of the people never appeal, whether it be medical care or even prescription drug coverage approvals. 80% of the people who appeal win. So it's often about advocacy on the world of managed care to make sure that the services that you believe and or the doctor is recommending is approved by the carrier. Are there certain carriers that are more likely to sort of put up a challenge than others? I would say that's probably true. But I have seen with advocacy, I've seen a tremendous amount of appeals work. So that's really a great, very insightful question. And it does impact people's experiences, previous experiences on what type of plan they want to move to. Great question. Any other questions, Sarah? No, I'll move on then.
Oh, we do have one other one.
Sure, go ahead.
If you have a pre-existing condition, is switching Part D problematic?
No. The only pre-existing conditions component is really around the medical side. As long as one has a special enrollment, again, if it's being done this time of the year, that's the time of the year to do it. But if one's changing mid-year for a prescription drug plan, it's really just a matter of having a special enrollment. There is no pre-existing conditions around Part D.
Terrific. And we have one more question that came in that also deals with the VA. I'm a veteran and part of the VA system for many years. I enrolled in an Advantage plan when I was 65 because I was told I'd be penalized if I didn't take it immediately. Is that still the case? If I drop the Advantage plan Medicare because I'm in the VA system, what are the disadvantages?
Again, great question, and thank you for your service. Being in an Advantage plan as a veteran is often a nice thing to have as a second opinion. Hopefully you're in a plan that's a zero premium, so you're not coming out of pocket. There are many veterans who don't even have Part B, so they don't have the choice. Again, I'm trying to look back to the question here. Let's see. No, yes, if at 65, you would have been penalized if you didn't get Part B, but you would not have been penalized if you did not get a plan. As long as you had Part B, you could get an Advantage plan at any time going forward. But as a veteran, getting Part B is often what I recommend. Even though there's a cost associated with it, it gives you the flexibility to not have to go to the VA facilities all the time, get a second opinion. In some cases, the VA doesn't actually cover every medication. So sometimes it's nice to have a secondary prescription drug plan as well, but they do not coordinate. The VA, and unless you really advocate for yourself, the VA and Medicare doesn't coordinate. They're paying their bills separately. Again, a great question.
And we have one more that came in too.
Sure.
Do you know the average cost of a Medicare supplement and standalone prescription drug plan per month?
Sure. So if you're talking New York, there are a couple of choices. On the supplemental side, there is currently there's Plan F, which is overpriced. That's over $300 a month. That's incredible coverage, but it's really priced out. People who are on Plan F can stay on it. Plan G is the new best plan. That is currently $280 a month in New York, but it's half the price in New Jersey, right? And so it depends on what state you're in. Plan N is $210 in New York, and again, half the price in New Jersey. But there is another option. It's called a high deductible plan. A high deductible plan is a plan where actually you're in Medigap. You can go to any doctor that you want that takes Medicare, but they have a $2,400 deductible and a $69 premium. So if you look at 80% coverage, right? If you have a bill for $400 and you have 80% coverage, 20% of that is $80. And so that would be your cost on a high deductible plan. When you got to $2,400 in out-of-pocket expenses, you would pay nothing going forward. Not everyone understands that kind of plan, the high deductible plan, but I have helped many people with it. But generally speaking, on the supplemental side, most often it's Plan N or Plan G that are two of the most common. On the prescription drug side, there is a carrier that is currently $7.20 a month, okay? They like CVS. They don't like Walgreens. So again, if you evaluate your prescriptions in the pharmacies that you use, there are plans as low as $7.20. There's also plans that are as high as $90 a month. And so it really depends on, what your dosages, frequency, names are, whether you have to use brand, how often you're using them, and really do the evaluation. Again, you can change your prescription drug plan every year on the Medigap plan. If you are on the Advantage plans, you are tied to the formula that Med Advantage plan has created. You are not able to change it. Now, we can back into it through the meds and your doctors. So it's a combination of meds and doctors on the Advantage plan. And so many people wind up just sticking with the formula because they want their doctors. On the Gap side, you can change it every year.
Thanks, Mark. We have a lot of other questions coming in.
Great.
Part 2 question of managed care. The appeal process is arduous, timely, and if you lose, they charge the patient for the waiting period. Is there another option to supersede the decisions? Is there an advocate for managed care or agency who oversees managed care?
Boy, that's a tough question. When I've done searches on that through Google and the appeal process, there are multiple appeals available, and it is an arduous process. I'm not going to disagree with that at all. I'm going to say that there are agencies within the state that I'm sure exist, but I can say that I have not been as involved in a number of those advocacy issues. So I'm not sure that I can answer that fully with helpful information. I apologize.
And just with managed care, you're signing up for a company for an insurance plan and the terms of that plan. So by enrolling in managed care, you're agreeing to their appeals process.
That is correct. You are agreeing to their fee schedule. You are agreeing to their network. You are agreeing to their drug formulary. Yes, and that's why people work with carriers that have a reputation for excellent customer service. Again, I'll mention, really the top three is really United Healthcare, Aetna, and Blue Cross Blue Shield. Though there are a lot of small companies, MVP, there's Health First, there's Oscar, there's a lot of carriers out there that really are working very hard to have concierge services for their clients, for their beneficiaries, and just do everything they can to support them in this managed care process. These carriers are hugely committed to two things. One, retention, meaning keeping the client and not having them move to another carrier. And they also are judged and they are rated based on star ratings. And their star ratings affect their profitability each and every year. So, there are surveys that go out from each of these carriers to try and, not from the carriers, but from CMS, that really try and identify which are the better carriers. And there is no 5-star carriers in New York, but there are 4.5-star carriers that I believe have excellent service. But managed care is still managed care. That is correct for all of you.
Okay, Mark. So is there a chart that compares drug coverage plans and their monthly premiums per person?
So Medicare.gov is really the go-to website. That's what we use. That's what most folks use in order to evaluate your prescription drugs. So the matrix per se that is created for Medicare.gov is, I wouldn't say clean and clear cut, but it is with a little bit of explanation, not that difficult to navigate. But there isn't necessarily a clean matrix. It's really about 3 different prescription drug coverage choices or Med Advantage choices with the prescription drugs included that Medicare.gov does give you access to. So I would always encourage people to access Medicare.gov for their own resources if they're doing some of this on their own.
Great. And we have one more question, and this is the last question we're going to take for the moment. We're going to let Mark keep going with his slides, and as questions come in, enter them in the Q&A, and we'll get back to answering your questions. So the question asker says, it seems New York is one of the few states that offer a high deductible plan. What's your experience? Do other states have comparable plans?
Almost all states have those plans. The high deductible plan is often not known about and not discussed by many people who do what I do. Often people think it's hard to explain. I don't believe so. I think it's an option that people who want the advantages of a supplemental plan where you're on original Medicare and understand what 20% of Medicare approved charges are. It is a reasonable plan, and most of in the states that I have looked at it, I have seen a comparable high deductible plan in every state that I've looked at. So for the moment, I'm going to continue with the presentation. I thank you all for the questions. This is a quick chart on the Part B and Part D income adjustments. Working with as many financial planners and CPAs that I do, this does make an impact on people and their decision to go on to Part B. Because if their income was high for previous years, they could be hit with an adjustment, not a penalty, but an adjustment to their Part B and Part D for income from previous years. It looks at income from 2 years ago. It's actually modified adjusted gross income. And you can see that 148.50, which is the current number, can go up to well over $500. So people who are retiring from a very good job might actually have to address this. The good news is that there's a life-changing event form. I help many people with this form, and that is a form that actually, if you're retiring or there's a change of life, divorce of some kind, there's 6 or 7 of them, that you can submit this and appeal this. And this is not a difficult appeal at all. And they can get it reduced because they are projecting what their income will be in the current year. So people who are retiring in 2022 and their income is dropping considerably can file this form. Once they get the form, the information from Social Security saying that their adjustment is occurring, they can appeal this and they can get this reduced. So this is really quite helpful. Okay, the next 2 slides are the summaries. The supplemental plans cover most of what Medicare doesn't cover. So again, 80% A and B. Supplement covers most, if not all, of what isn't covered by original Medicare. It's simple, has the most freedom, national coverage, easy to understand. It's really the preferred choice for the more affluent consumers where premium is not an issue. Though again, New York is unique. The coverage is by letters. I've mentioned F, G, N, there's other letters. And they're not necessarily more comprehensive as you go up the alphabet. Plan F, yes, is the most comprehensive. Anyone on Plan F will grandfather or grandmother into the plan. And yes, it is the most comprehensive of all the plans that are out there. But anyone who is turning 65 after January 1st, 2020 can no longer get Plan F. So that's the only rule that has changed the way in which Plan F is being sold. These premiums vary by state. $100 to $300 is really the range in 2021, but they're standard. They're standard across all around the country. So New York, Connecticut, Massachusetts, actually Massachusetts would be an exception, but California, all Plan Gs, all Plan Ns are 100% exactly the same. The only difference is price. This is not network-based. 95% of all doctors in America take Medicare, but not 100%. So if they don't take Medicare, they don't take these plans, and there's really nothing else one can do except to pay what the services and not go through Medicare. Maximum flexibility, minimal friction, but there's no drug coverage included in this at all. Med Advantage plans, again, the most popular plans in America. A lot of the unions, a lot of the school districts, New York City employees, it's a huge amount of companies, organizations, institutions are moving to these Advantage plans. They're offered again through private insurance companies. These private insurance companies are competing heavily for this business. And they're a bundle. They're a bundle of the hospital, the doctor, the prescription drug, all in one package. So it's different. They're all different and they all have to be reviewed. But they're low premiums. They're often as low as $0, but they have cost sharing. Cost sharing basically means you're paying, besides your Part B premium, you're still paying for co-pays, maybe some co-insurance, maybe a deductible, but you are sharing in the cost for each service you use. They vary greatly by county, all across the country. The maximum out of pocket for 2021, as I said earlier, is $7,500. But they offer these additional benefits that people are speaking of, vision, dental, gym memberships. These ancillary benefits continue to grow and improve each year. Some offer over-the-counter, transportation, some food delivery, right? And so it really depends on the carrier and, again, your doctors. They are network-based. And so you have to be sure, even if we determine that all of your doctors are currently covered, if you go to additional doctors, you want to make sure that you call the carrier and check to make sure that you can see that doctor. If you call the doctor's office, they generally know the answer, but I would always feel more comfortable in calling the carrier and making 100% certain so that you're not surprised. And again, in New York, healthy boomers without chronic conditions are certainly considering this because of the low premium. this is hard to see, but this is the work that we do looking at your doctors. So it's the doctors, it's the facilities, and it's the carriers. So we basically put together an Excel spreadsheet and we look at all your doctors and we go to each and every one of the carrier portals and we take the time to help you make that decision that's right for your Medicare. Prescription drug plans, and I know that I'm getting close to the top of the hour and I appreciate the questions and I hope this has been valuable. The prescription drug side of the business that I'm in is one of the most important things that we do, because there's no limit to the cost of prescription drugs and there's no limit to the amount of assistance that some people need to be able to find some cost reduction on prescription drugs. There are 4 stages of prescription drugs, which of pricing. So the price of a medication could be $700 to start, go down to $100, go back up to $300, and go down to $45. And so that roller coaster of prescription drug costs is what we help people understand and really budget for. So the better the list that we have from someone in terms of the frequency, the dosage, the pharmacy, how often they're really using a medication. Is it as needed? Or is it, you can use a tube of a cream for 6 months, right? All of those things will play into this. Again, the deductible, as I said earlier, going up from $445 to $480. So that's a decent increase. But, you know, in the Med Advantage plans, there's no cost for this, for these prescription drug plans, but there's still, you're still paying the copay. The standalone plans, again, it ranges, I'm going to say the average of $20 a month. Still, one needs to pay the copays. These are designed by tiers. There are 5 tiers of prescription drugs. There's generic, there's preferred brand, there's specialty drugs. All of this impacts people's ability to understand the cost going forward through the year. There are preferred pharmacies and there are standard pharmacies, meaning that if you go to a preferred pharmacy for some medications, you'll pay less than if you go to a standard pharmacy. Mail order may be cheaper and may not be cheaper. And so again, all of that information is a part of what is important for you to know and to evaluate. These prices change yearly, but there's also discount cards. So in the work that we do, we help people look at GoodRx, Single Care, as 2 discount cards that are available that are separate and apart from Part D. So you can walk into a Walgreens with your GoodRx card and get a discount on a medication that you would typically put onto your Part D plan that actually would give you a better price. There are also grant programs that are out there through some of the pharmaceutical companies based on income, and also grant programs based on the impairment that you may face that are available really often at the beginning of the year. Medicare.gov is where we go. Medicare.gov is where you can input your information. But we spend a lot of time all through the year helping people understand the changing world of prescription drug coverage. I'm going to skip this one. So I only show this screen briefly because this is one of the carriers' dental options. And dental is important these days, dental and vision. And so this one carrier has a dental package for $24. They offer up to $2,000 worth of dental coverage. You're in their network, right? And there's a $50 deductible for comprehensive services. That's nice. It's a rider though. So even though the premium on the plan may be $0, this is a rider that you can add, but you do need to go to a network doctor within this carrier. And if you add the vision, it's not much more, and you get up to $200 worth of glasses or contacts. So I just wanted to show that because I think it's helpful. Okay, takeaways. We're almost at the end, and again, I'm happy to answer questions and stay on afterwards. But each person's needs are unique. I think that you hear that, is that, you know, 2 people in a household could have different doctors, different medications, and afford different plans. But it's based on your health, your budget, and the current coverage that you have, whether it's group coverage, whether it's retiree coverage, whether it's veteran coverage, whether it's your spousal coverage. All of these make a difference. And the timing of Medicare Part A and B, again, based on the poll questions, I have a sense on how many of you are on A and B, or how many people are on different plans. But for those who are looking at Medicare and approaching 65 or retirement, these are important pieces of the discussion as Part B in the timing. Review and evaluate your group coverage, because the group coverage could be really good, and it could be good for the employee, but maybe not so good for the spouse. So worth looking at. We always recommend looking at your doctors and your medications closely, because at the end of the day, that's how Medicare really operates. But of course, there's always budget. Advantage and Medigap. I hope that I've covered that in enough detail to give you a good overview of it. Again, each person's needs are different. Find an independent, experienced, trusted advisor. My services are free. There are, through the library system, there's SHIP, there's the Office of the Aging in Rockland. There's so many organizations that can help guide you on this Medicare road that are really worth pursuing to get the right advice and the right guidance so that you make the right decision for your own health and your own budget. So this is me. I represent 17 carriers in 15 states. I'm local. We're around all year long. We love what we do, and I'm open for questions.
Mark, thank you. Such a terrific amount of information and the slides, and we've had a number of requests already for your slides after the program, which we will be posting along with this program, hopefully on our website, seniorlawday.info, as well as on YouTube by Friday. So we have a lot of questions that have come in, as well as a number of thank yous in the chat. So a participant asks, if the family decides to supplement the higher payment option, is it tax deductible?
So on, again, I'm not a tax guy, but on the Schedule A, it certainly would count towards the medical costs component. If one actually had an HSA, one can sort of take that money out of the HSA and utilize it for that purpose. And so those would be the answers that I can provide.
Very good. And to deduct medical expenses on your income tax return, they have to be 7.5% of your AGI. In New York State, high deductible plans are not offered by United Healthcare, Aetna, and Blue Cross. Who does offer such high deductible plans?
That's a great question. Globe United American is one, and Humana is another. Again, Globe United American is a very well-regarded company, but not often a name-recognized company. I've had good success with both Humana and Globe, and again, in other states, there are other high deductible carriers, but you're right, those three carriers do not offer high deductible plans at the present time.
Another participant asks, is Plan F still around? Does Plan G replace Plan F?
So Plan F is still around for anyone who has a birthday, a 65th birthday before January 1st, 2020, they can still get Plan F. Plan F is still being sold. And anyone who has Plan F will be able to keep Plan F. But the new Plan F in the world of anyone recently turning 65 is Plan G. And the only difference between Plan F and Plan G is the one time, the beginning of the calendar year, there's the current $203 deductible for Part B. It will be $217 in 2022. That is the only difference between F and G. If you divide the $217 by 12 months, it's about $17, and the difference in price is about double that. So most people who are looking at plans are no longer looking at F. But yes, F is still available, and people who have F can keep it.
Thanks, Mark. A participant asks, if I have an Advantage plan and I'm traveling within the United States and get sick somewhere else, how does my coverage work?
Again, great question. So emergency rooms are covered anywhere in the world. But when it comes to United States coverage for these Advantage plans, again, if it's outside of the emergency room and you find yourself being in a place for a month or so and needing other care, then one would hopefully be able to call the carrier and ask for a provider of that service in the area in which you are. That would always be my comment. I wouldn't trust that the billing people would necessarily know of a plan in New York if you're in Chicago, but your carrier will certainly know the answer to that. And that would be always what I would suggest, is making sure so that you have no surprises.
So the next question, what are the rules for switching back and forth between original Medicare and an Advantage plan?
So again, the time of the year matters. And so this is the time of the year. If you have original Medicare and you don't have a supplement, so that means you just have A and B, then your time of the year is this time of the year, which is open enrollment. Again, the Part D part is the challenge. But if one is going from original Medicare to Med Advantage, one has to wait for open enrollment. If one is going from original Medicare and adding a supplement, one can do that any time of the year, but they can't necessarily get a Part D plan. So it depends a little bit on the specific scenario, but not all scenarios would work.
And I guess the answer is, if in doubt, give Mark a ring after the program. So the other question that came in, if I receive a grant, do they generally cover medication for a year?
So the grant will be for a certain amount of money. And so it could be 2,000, 5,000, 10,000. I've seen all numbers. And it is for however long it takes for you to utilize those funds. So generally speaking, these grants are renewable each year in some capacity. So anyone who is seeking a grant, this is the time of the year to do the extensive research to try and find a grant program that you can apply for. And I would apply for multiple grants to see which, in fact, you might be able to get. But the grants are usually issued sometime in the first quarter of the year. So that would be, the earlier you get involved in the process, the higher likely it is that you'll be in the queue.
Terrific. So if anyone has any additional questions, please enter them in the Q&A now.
And if not, I'm just going to take, well, you have one more question. It looks like there's
It was just a thank you to Mark.
Okay.
Well, thank you all.
Yeah, great job, Mark.
Mark, we have a question that came in. So after Bruce shows our website, we'll just show Mark's contact information one more time. And the question is, if I want to schedule a consult with you, Mark, with Emerald Medicare, how do I go about doing it? So we'll let Mark answer that after we just show you our senior lobby website.
Okay. I just wanted to point out that another option for getting advice on these questions in a private way is on, as you can see on the website, on November 18th, we're having one-on-one consultations via Zoom. Unfortunately, Mark is not available that morning, but we will have a Medicare specialist from the Westchester Library System available at that time. So you just go to seniorlowday.info on November 17th anytime and sign up. And if you're on our email list, we'll be sending a reminder, but you can also notate your calendar. And then I just wanted to just take a moment, thank our sponsors, including Emerald Medicare, for making these webinars possible. So that's what I had to say, and then I'll just take it back, after Mark for just one more minute.
And if you have a question that you forgot to ask us on the website, right where Bruce's mouse just was, there's our Ask Us button. So type your question into the Ask Us button, and we will get right back to you and get your question to the appropriate attorney, certified financial planner, Medicare expert, or geriatric care manager.
So I'll just answer that. I usually start with a phone call to understand the situation that people are facing. And then if a Zoom or a follow-up meeting is asked for, I'm happy to provide that. But my services are free. And our team at Emerald Medicare is here all year long to answer questions and to provide you with the best solutions for your health and your budget.
Bruce, can you just put Mark's last slide back up with his phone number and his email? So if someone wants it, they can write it down.
I think the best thing to do would be just Mark, put that in the chat, or I'm just going to launch a quick poll right now where we can find out how, or I can put it in there. So Mark, what is the best way? You want the phone?
845-358-1220. I want to thank you, Sarah and Bruce, for allowing me the opportunity to educate the community.
Yes, thank you, Mark. We look forward to having you back soon.
Thank
And
you.
thank you to everyone who joined us this morning.
And thank you to all of you who have lasted for almost an hour and 15 minutes. And we will end the webinar now. All right, have a great day.